Hi everyone, and welcome to our 7th week of the 3P seminar series. And this is brought to you by collaboration between the Cure Parkinson's Trust, World Parkinson's Coalition, and the Van Andel Institute. Today we have a special MSA theme session where we have a graduate student presenting the first part of showing some research in the MSA field. And the second portion of this session will include an MSA patient advocate who Lisa will introduce as the second speaker. So our first speaker today is Raphaella So. Oops, sorry, one moment. Who is a PhD student at the University of Toronto, and she is studying alpha-synuclein diseases in the context of conformational strains. So over to you, Raphaella.
Thank you, Mickey, for the introduction. And first of all, let me get the screen set up. Okay, so can you see my screen? Okay, I'm assuming that's a yes. And so good afternoon, everyone. I am Raphaella So. I'm a PhD candidate at the University of Toronto, Canada, in Dr. Joel Watts' lab. I am very, very honored to be here today and to tell you about my studies on alpha-synuclein diseases in the context of conformational strains. Alpha-synuclein aggregates are a common pathological hallmark of several diseases, including the theme of today's talks, multiple system atrophy, and as well as Parkinson's disease and dementia with Lewy bodies. And what's very interesting about these diseases is most patients actually do not harbor any mutation within the alpha-synuclein gene itself. So how this same wild-type protein can aggregate in different ways and wreaking havoc upon so many different brain regions, cell types, and cause these different diseases is a mystery. And we think that clinical variability may be due to the structural differences in not the wild-type alpha-synuclein monomer itself, but in its aggregated form. And we call this difference the conformational strains. Conformational strains, this concept can be more easily visualized in snowflakes. So we know that snowflakes, they come in all shapes and sizes, and they make very unique, beautiful patterns, even though they're made out of the same water molecule. And so this same water molecule can, for some reason, form different frozen crystals, which then would seed all these beautiful patterns that you see on the right-hand side of my slide. Applying that same concept to alpha-synuclein monomers, which can misfold and aggregate into different conformations, which then will seed the different strains, we believe that these structural differences in the conformational strains would underlie the different diseases that we see in human beings. Indeed, patient-derived alpha-synuclein aggregates are conformationally distinct. So in our recently published paper, my colleague Heather Lau actually did an experiment where she took a chemical denaturant or a chaotropic agent and then tried to pick apart the alpha-synuclein aggregates derived from human patients. And the rationale behind this experiment is we would be able to infer structural differences if we find something that is, for example, more easily picked apart, like a loose knot right here, or very difficult to pick apart if it could be picked apart at all, like this very tightly loops together knot. And so applying this concept, she found that the MSA-derived patient alpha-synuclein were a lot easier to pick apart than dementia with Lewy bodies or Alzheimer's disease patient alpha-synuclein aggregates, meaning the MSA patient aggregates were less stable. And this is only one measure of conformational differences. Other groups have reported very similar findings in terms of finding different conformational strains, but using different experimental methods with patient-derived material. One obvious way is to model disease strains in mice is to directly inject human brain samples into them. And so if you inject an MSA patient brain extract into transgenic mice, or at least this mouse model that they used, these mice get a lethal neurological disease, but this disease does not resemble human MSA per se. And meanwhile, Parkinson's disease patient brain extracts, when injected into transgenic mice, you couldn't really see a visible phenotype or a very obvious phenotype in this mouse model at all. And so in our lab, we want to use something that could more accurately model these diseases in mice by injecting them. And we've turned to recombinant alpha-synuclein. So the reason we use recombinant material is if you have purified protein, then theoretically you can subject it to whatever laboratory environment you'd like, which means the possibilities of making conformational strains would be essentially infinite, hopefully, right? So if we test these putative conformational strains in mice, and then we find, for example, the cloud strain when injected into mice looks like human MSA, or the pentagon strain when injected into mice look like Parkinson's disease in humans, then we've really hit our jackpot. And actually other labs have also looked at making different conformational strains from recombinant alpha-synuclein, and they found ribbons and fibrils, which actually do have differences in their physiological consequences. So before I talk about the approach that we use, just wanted to introduce the team behind most of the work that I'll be talking about today, myself as well as the previous grad student, Master Angus Lau. And for me at least, sometimes with the occasional help of a special solution that I promise is only consumed after hours, I promise, Joel. Okay. Anyway, we purify recombinant alpha-synuclein monomers, and then we let them aggregate in vitro in test tubes, and then we would analyze these fibrils biochemically to look for putative differences in the strains, and we would try to inoculate transgenic mice with these different strains to look at the biological effects downstream. And one easy way to visualize conformational strains in the lab is by protease digestion. So this is an experiment that uses proteinase K, which is an enzyme or a pair of molecular scissors that whenever it sees protein, it will chop it up into pieces and kind of make it disappear. So monomeric alpha-synuclein, which is not aggregated, would be completely exposed to this enzyme and get completely degraded in the process. And if you have some sort of protein aggregate, parts of it would get shielded from the enzyme so that you would have some level of undigested material. And if you have multiple strains of aggregates, then the parts that are shielded inside would be different. So you would see different shapes and sizes of these undigested materials, which you can actually visualize in the lab in a very clear kind of banding pattern. So in this example shown on the right-hand side, the 2 lanes on the left are of one pattern, the 2 lanes on the right are of a different banding pattern, and we would interpret these 2 sets as different putative conformational strains. We use A53T alpha-synuclein, which is a pathological mutant of Parkinson's disease. And so we take the recombinant protein and we either add salt or we do not add salt. And then we just let it shake, shake, shake in a machine for 7 days to make salt or S fibrils or no salt NS fibrils. The right-hand side shows you the proteinase K digestion results. Salt fibrils after digestion displayed one pattern. Meanwhile, no salt fibrils after digestion displayed a different pattern. So putatively distinct strains. And remember, we wanted to look at the biological effects because we want to do mouse modeling. And so we inoculated M83 hemizygous mice with our recombinant fibrils. These mice overexpress A53T mutant alpha-synuclein but do not spontaneously develop disease. And at 5 weeks of age, we inoculate them with the fibrils, and then we wait for symptoms to appear. The nice thing about working with this mouse model is the symptoms that come are really obvious to the untrained human eye, and they include paralysis, weak grip strength, and weight loss. And these mice at the end actually get very sick, and we sacrifice them for their brains to do analyses. And the time between inoculation and sacrificing is called the incubation period, which we use as another measure for distinctness in conformational strains. A53T salt and no salt fibrils induce distinct disease incubation periods across passages. What is a passage? Fibril injected into mouse. First passage, this mouse gets sick, we take its brain, we grind up its brain. I'm sorry this is getting graphic, but we grind up its brain and we take that homogeneous material and we inject it into a second batch of mice. And this is called the second passage mouse. And then so on and so forth, we can create multiple passages. For the purposes of this experiment, we created 3. And so this is a Kaplan-Meier curve showing you the results. Asymptomatic animals in percentage across time from inoculation in days. If all animals in the cohort are healthy, this would stay at 100%. If all of the animals got sick, then this curve would drop to 0%. So as time goes by and as more animals develop the illness, then the curve goes down. PBS is our negative control. It is just saline injected mice, so all of them remained healthy. Black cluster right here is salt fibril inoculated mice, first, second, and third passage. And red cluster is no salt fibril inoculated mice, first, second, and third passage. And the general trend is that salt fibril inoculated mice developed disease faster than no salt fibril inoculated mice. And this difference was maintained across the 3 passages. Looking at the protein deposition patterns within the brains of the fibril inoculated mice, we stained for a pathological marker that is phosphorylated alpha-synuclein at serine 129. And so this shows up as brown staining in histology. Salt fibrils are shown, salt fibril inoculated mice are shown in the top row, first, second, third passage. They generally displayed a round kind of ring-like inclusion pattern that is drastically different from the no salt fibril inoculated mice, first, second, third passage, that show you a dense blob, essentially, that may look like Lewy bodies. So there's difference in structure of inclusion, and this difference is maintained across the 3 passages. And then we looked at the biochemical properties of the inoculated mice after proteinase K digestion. First of all, on the left-hand side, just to remind you what the recombinant fibrils themselves looked like. So we've seen this before, salt fibrils and no salt fibrils after digestion looked different. And so after passaging in mice, if you look at the salt fibril inoculated mouse first passage and the no salt fibril inoculated mouse first passage, they also had a distinction in the banding pattern. These 2 banding patterns do not resemble their parent inoculum, but they themselves are distinct between each other. And this distinction is maintained across the 3 passages. So to conclude this part of my presentation, A53T alpha-synuclein can form distinct strains causing different diseases in mice. And one point to note that I didn't really get to is we could compare the salt fibril inoculated mice using these phenotypic readouts with human MSA patient brain sample inoculated mice. And we actually found some striking similarities between these 2. And this is reported in our paper if anyone is interested. So, but unfortunately, neither strain, salt or no salt, is exactly like Parkinson's or multiple system atrophy aggregates. And so we wanted to see if we could make even more strains that could more accurately model these diseases. And so remember how I told you that the human patients, most of them don't have mutations within alpha-synuclein. And so we wanted to model that in the lab by using wild-type alpha-synuclein recombinant protein. And so we added salt to this preparation, and then again, the shake, shake, shake protocol to create what we call thermomixed or T-fibrils. Alternatively, we subjected them to a different kind of agitation method. This is periodic sonication, or essentially bursts of ultrasound every 30 minutes. And these fibrils are called PMCA, P fibrils, or in its long form, protein misfolding cyclic amplification. And the right-hand side shows you the proteinase K digestion results. PMCA fibrils display a different pattern than the thermomixed fibrils after digestion. Showing you another replicate of my fibrils because 5 out of my 6 thermomixed replicates looks like a hamburger after digestion. 1 out of 6 of my replicates was missing a hamburger's bottom bun. Meanwhile, all 6 of my PMCA replicates looked the same after digestion. One extra type of fibrils I made was 5 mg per mil thermomixed fibrils. Reason being that we make our fibrils generally at 1 mg per mil. Other labs have reported higher concentrations like 5 mg per mil, and we wanted to check whether or not we were inherently making a different strain from the rest of the field just by having a different protein concentration. And so from this experiment, we see no matter it's at 1 mg per mil or 5 mg per mil monomer concentration to begin with, thermomixed fibrils also look like hamburgers, so they look the same. And for the inoculation experiments I'll be talking about, we'll be using PMCA, this generic looking one, thermomixed variants 1 and 2, as well as the high concentration thermomixed fibrils. So we conducted the mouse inoculation experiments in 2 dosages. One batch of mice received 10 micrograms of total protein, while the other batch of mice received 1 microgram of total protein. And let's look at the 10 microgram experiment first. Monomer injected mice, even at 10 micrograms, did not develop disease. Meanwhile, all 4 fibril inocula caused these mice to all succumb to the disease. And for the 1 microgram injection experiments, the fibrils that we tested, which is the PMCA as well as 2 of the thermomixed fibrils, they all caused mice to develop disease as well. And actually, if you look at the disease incubation periods, they're not all that different, even though there's a 10-fold difference in the protein amounts that we injected them with. So looking again at the neuropathology of these mice, first of all, let me show you what the negative control looks like. Remember, monomer injected mice, even at 10 microgram injection, did not develop disease. Meanwhile, remember, we're looking for brown staining, thermomixed 10 microgram injection, there's very clear brown staining for the phosphorylated alpha-synuclein. PMCA 10 and 1 microgram injection, 5 mg per mil thermomixed 10 and 1 microgram injection, and finally thermomixed number 2, 10 and 1 microgram injection. Essentially, all of the fibril inoculated mice that we looked at were stained positive for this brown phosphorylated alpha-synuclein, and we could find the ring-like structures within each slide, which would be reminiscent of what we generally saw with the A53T salt fibrils. Looking at the proteinase K digestion patterns. So left-hand side is 10 microgram inoculation, right-hand side is 1 microgram inoculation experiment. The red boxes remind you what the recombinant fibrils themselves looked like before inoculation. Remember that the PMCA and thermomixed fibrils had different patterns, and there was differences in the patterns of thermomix number 1 and 2. This orange box shows you the negative control, which was the monomer 10 microgram injected mouse. Remember, they did not have disease, nor did they have neuropathology. So naturally, as we expected, nothing came up in this lane. The purple boxes show you what happens to these recombinant fibrils after 1 passage in mice. So remember how we started off with what looks like distinct fibril strains? What we ended up was alpha-synuclein aggregates that looked the same after proteinase K digestion. And so this was true for both the 10 microgram inoculation experiment as well as the 1 microgram inoculation experiment. Everything essentially just looks like 2 heavier bands with 1 lighter band at the bottom. And if you feel like you've seen this patterning somewhere before, it is because this is reminiscent of the A53T salt fibril inoculated mice, which also looks like this. Meanwhile, the no salt injected mice looks completely different. So distinct in vitro strains do not guarantee distinct in vivo strains. In the first part of my talk, I talked about A53T salt and no salt fibrils, which were of distinct strains, and when injected into mice, caused distinct diseases, pathologies, and maintained distinct proteinase K digestion patterns. Meanwhile, wild-type PMCA and thermomixed fibrils, they started off looking like distinct strains, but somehow after inoculating into mice, we couldn't see there was a distinction in disease or pathology, and their proteinase K digestion patterns kind of converged into something that resembles the A53T salt fibril inoculated mice. So in the spirit of the chromatin haiku movement on Twitter, this is my synuclein haiku, which is conformation strains, distinct diseases in mice, not always the case. And with this, I would like to thank the Watts Lab, especially my supervisor, Dr. Joel Watts, as well as my mentor / the previous grad student, Master Angus Lau, and collaborators within the TANS as well as outside of the TANS, supervisory committee members, Drs. Peter Kim and Anurag Tandon, funding sources Parkinson Canada and Croucher Foundation scholarships, my parents, and thank you very much for coming. I'll be happy to take any questions, and also, you know, if you want to follow up on me, you can do that through my socials. So thank you.
Thank you, Rafaela. So just a reminder for anyone who's new to the 3P seminars, if you look at the bottom of your screen, there's the Q&A feature, which you can submit questions to now if you have any questions. But to start off, we have a question from Kurt in the audience who asked, do the different alpha-synuclein strains result in a difference in which cell types that they accumulate in after the inoculation? So is there any differences or similarities with MSA versus the PD?
Okay, so for the case of salt fibrils versus no salt fibrils, generally we saw neuronal inclusions for the most part, and there is actually a very research just technical reason for that. It is the M83 promoter is the prion promoter. So natural expression patterns are different. So for that, then, you know, salt versus no salt, cell type wise, most of it is still in neurons, but there are like minute differences in terms of where the neurons are, like where the neurons have the inclusions. So we did find some differences in like the distribution across the brain. Even with like MSA and PD inoculated mice, remember PD for our experiments, we don't really see much, but for MSA inoculated mice, they don't really get the types of like glial inclusions that we see in human MSA, which is why my argument was that, you know, MSA injected mice don't look like human MSA.
And I guess a follow-up on that is, can you speculate on why these human MSA and PD patient brain extracts didn't get the same disease as they present in humans?
Okay, so first to answer why MSA doesn't look the same, first of all, just let's say in wild type mice, actually mature oligodendrocytes do not really express alpha-synuclein. So unless there's a disease state that primes them for expression, you don't really have that expression. Hence, if you inject a wild type mouse with MSA aggregates, the chances that they'll get glial inclusions, not that great. And as I said, the M83 promoter is prion promoter, so that does not reflect human MSA patient expression patterns in the brain either. And finally, we actually don't know exactly which part of the MSA human brain extract is the transmissible species. It could be the neuronal inclusions within those patients, or it could be the glial inclusions. And if it's the neuronal inclusions that transmit, then of course we don't see glial inclusions in mice as much. Now going back to the Parkinson's disease mouse model, well, my colleague Heather has found that the stability, like using that chemical denaturant experiments, the stability of Parkinson's patient alpha-synuclein is very high, meaning it's very difficult to pick apart. And if you can't pick apart something so that smaller pieces can transmit, then the chances that there's cell-to-cell transmission would potentially be lower. So all speculation, but this is what we believe is happening.
Thank you. Very good answer. Another question here from Miguel is, what are your thoughts about the salt-treated fibrils seeming more pathogenic? Do you think salts are disrupting the interaction with chaperones?
So the salt concentration we use is actually pretty consistent with physiological concentrations of just salt within normal cells. So we don't think the salts themselves per se are more like would disrupt chaperones. Exactly. But what we think happens with these salt fibrils is, well, we know that they fold differently than the no salt fibrils. And this folding might actually be more favored to transmit in the mouse model. So like imagine if each mouse kind of had a sort of selection of the types of strains that it likes to propagate. Somehow our salt fibrils kind of met that preference.
Excellent. A question here from Villa. Did you also try the salt versus no salt conditions when you looked at the wild type alpha-synuclein?
Yes, we did. There's really no good reason why we haven't expanded beyond what we initially tried, but we did try salt versus no salt, both thermomixed and PMCA, and very initial results that show that indeed no salt thermomixed wild type alpha-synuclein fibrils are different in proteinase K digestion than the salt ones. But if we do PMCA on them, then no matter salt or no salt displayed the same PK digestion pattern. So yes, we've tried it, and there's really no good reason why we didn't follow up on it, but it's just happened that way.
Okay. Another question from an anonymous attendee. Have you compared your strains using electron microscopy to see if they have distinct morphologies in addition to looking at their PK profiles?
Yes, so it's in the works because we have a collaboration who does that for us. And so Holger Ville's lab in the other parts of Canada that I'm not as familiar with. But so for salt and no salt fibrils, we actually have published that they are of different electron microscopy shapes. And in our publication, we also showed some preliminary results from PMCA fibrils of the wild type alpha-synuclein, but we have yet to get the EM images for thermomixed fibrils.
Thank you. A question from Kurt. Have you tested whether the different alpha-synuclein strains show a difference in the speed of the alpha-synuclein pathology induced when it's spreading capacity, e.g. from the gut going to the brain?
That is in the works right now.
Okay, so
yes.
Keep an eye out for that.
So yes, maybe in a few years, hopefully before I graduate, we'll get that paper out.
Excellent. I guess a similar kind of question from Hale. Have you tried to inject the fibrils in any other mouse models overexpressing wild type alpha-synuclein?
Overexpressing wild type alpha-synuclein. We ourselves have not. There are multiple other studies that have done very similar things. And so far what I'm seeing in literature is that the A53T expressing model is still the most easy to spot in terms of obvious endpoints. So that's why we stuck with it. But yeah, these models exist.
Okay. Question from Jake. Do you have plans to look at how these different strains may be differentially truncated after seeding?
We have not really exactly thought about this question, but I can see how one can do that with different antibodies that looked at the different parts of the epitopes of the protein. But yeah, it's a very interesting, I would say it's a very good kind of future direction for our work that we have yet to consider, but will in the future.
Maybe one final question here from an anonymous attendee. Why did you choose this mouse model? Have you thought about testing it in another model which overexpresses alpha-synuclein in oligodendrocytes? Sorry.
Yes, so we know that these oligodendrocyte expressing models exist. In fact, Peng et al. 2018, a very highly cited one about that. I mean, yes, theoretically we can acquire those, but other labs are already doing it, and there's going to be significant overlap. And realistically, my PhD is only so long. Do you really want to put me through a 10-year PhD, Joel? So yeah.
Okay. Thank you. Thank you for a great presentation and
Thank
for
you.
answering all of our questions. We've got a couple left, which we'll post on the 3P discussion Facebook page. So if you want, if anyone else has any additional questions, feel free to use that as the forum. Now I'll pass it over to Lisa, who will introduce our second speaker for today.
Thank you so much, Mickey, and thank you so much, Rafaela. That was a really great presentation. I learned a lot, and it was super pedagogical, so it was really easy to keep up with your research. And now we're gonna shift gears a bit. I'm gonna introduce you to Beverly Wilson, who's a MSA patient advocate, and she has a very, I really like the title of her talk. It's Extraordinary Healthy, Except for MSA. So please go ahead and share your screen and start your presentation, Beverly.
Thank you, Lisa. I would like to thank all of you for the honor of representing MSA patients. I'm a 65-year-old woman living in Michigan. I'm the human container for the folded alpha-synuclein protein in my brain. So I'm grateful for people who are studying it. I will share my screen. And this is something you'll hear over and over from MSA patients. They were so healthy. What happened? This is what it looks like from the outside when you're the patient and you're not doing the research on the inside. Many patients will say, I was so healthy. I was a surfer. I was a fitness trainer. I was a phys ed teacher, a mountain climber. And then all of a sudden start to get these weird symptoms. So it just doesn't make sense. Prior to my MSA diagnosis, I had not really had any surgeries: tonsillectomy, adenectomy, age 4, wisdom teeth extraction, age 20. As a nurse, I managed an inpatient psychiatric unit in a local hospital, very stressful job. Adjunct faculty teaching grad courses at a local university. I'm a grief therapist and was the owner of a grief therapy practice. I was a PhD candidate, but have been unable to finish my dissertation because of MSA. And I was retired but physically active. We had a Grand River expedition in 2010 here in Michigan. I paddled 363 kilometers and over a 2-week period. It was great fun. So if you look at the timeline of this, it really stretches out. At age 44, I had the first episode of unexplained urinary incontinence. It made no sense that it had such an impact on me. I remember exactly when it happened. And then at age 55, when I was doing this paddling trip, I felt more fatigued than I thought I should be. I thought, I don't like this aging thing. I'm getting older faster than I thought. It just didn't feel right to be so tired when I was a good paddler. At age 57, I had my first unexplained fall. I didn't faint, didn't trip, just went down for no reason. Then at age 59.5, I had a vertigo attack, and I began to search for the diagnosis. Something is wrong. Nothing was ever right after that. And then at age 63, almost 64, there was finally a diagnosis of MSA. So I'm going to take you through some of the diagnoses that were suggested to me on this journey. No one could figure out what it was. It was just a challenge for all MSA patients. It takes 2, 3, 4, 5 years to come up with a diagnosis. So we appreciate all the research that's going on in the background to at least be able to come up with biomarkers or something to pinpoint this. First was benign paroxysmal positional vertigo. That was the attack that had me in the emergency room. It was pretty gruesome. I never had anything like that before. Another doctor, that was an ENT who diagnosed that, did some MRIs. Another EMT surgeon said it was chronic migraines, but he did say, I remember, something weird is going on. You need to see a neurologist. So I saw a neurologist. Neurologist number 1 said you had strokes, hardening of the arteries, hypertension, hyperlipidemia. Hyperlipidemia was not really there. It was just I was at the upper ends of normal. I went on a cholesterol-free diet, and all the results went up. Hypertension was probably related to being postmenopausal and the stressful job. Once the stressful job was gone, the hypertension came down. Hardening of the arteries apparently was no different than anyone else my age. It wasn't a marker. Strokes, she said strokes, someone else said migraines. They couldn't agree on that. I kept saying, this is something neurological. I demanded neuropsych testing. He said, you have depression. I've never been depressed. I thought, if I have depression, it's because nobody can figure out what this is. Chiropractor said I have autoimmune disease. Podiatrist was trying to help me walk, said we can try shoe inserts. The rheumatologist says, I see no evidence of autoimmune disease. The cardiologist said, your heart's fine, try a gluten-free diet. But finally, I said I need speech therapy, occupational therapy, and physical therapy. So the LSVT speech therapist said, it's not Parkinson's. The LSVT physical therapist said, if you have Parkinson's, it's mild. Then I went to a neurosurgeon, can you help me walk? He said, well, I can do back surgery, but it won't help you. And finally, neurologist number 2 said, I'm treating you for Parkinson's, but I'm not convinced that's what it is. This is over 4.5 years, almost 5 years. Quite a struggle. So believe it or not, through Facebook, somebody sent me to a doctor at the University of Chicago, and I went in on May 1st of 2018 after almost 5 years of trying to figure out what this is, with this exact list I'm giving to you, and all the list of the misdiagnoses I had. And this list is ranked by degree of impairment. First was slurred speech. I had a puffy mouth, but I could feel my speech was slurred. This has been one of my biggest losses from MSA because I had a beautiful speech. I did radio readings for the blind. I had a national voice contest for an answering service before cell phones were popular. There was just no reason for slurred speech. Then second to that was the abnormal gait. I was using a cane for distances in airports and unfamiliar places. For 2 years before the diagnosis, I kept saying, I am overwhelmingly fatigued. Yeah, I was doing a lot of stuff, but I shouldn't be this tired. I had muscle weakness, diminished fine motor control. I used to be very fast on the keyboard and it was really getting sluggish. My activities of daily living were becoming more difficult, just stressing myself and moving around. Yawning was difficult. I was not tired when I was yawning, but in a conversation I was yawning. Number 7, I had my feet do not move when falling. If I started to fall backwards, my feet were just like they were planted to the ground. They couldn't go backwards to catch me, and that was new for me. Restless legs would wake me up in the middle of the night, and I'd have to walk to relieve the pain. And here's the rest of them. Slow everything. I was not used to being slow. Everything, dressing, moving, thinking, everything seemed slow. I had a left-sided weakness that affected my hands and my feet. I had trouble even picking up a paperclip with my left hand, and this had come on suddenly with a vertigo. I had some difficulty swallowing pills. I had urine incontinence. I had rash on my arms, intermittent. I could tell my depth perception was slightly off. I knew driving the car, and I've been driving for decades, but suddenly if I would get close to a car, I wasn't as close as I thought I was. I'd stop farther back or close to a curb. I thought I was up next to the curb, and I get out and look, well, the curb's so far away. That didn't make sense to me. And my jaw would drop when I'm just sitting, talking to somebody in conversation, listening. My jaw would drop when resting. And I had some drooling, which was, that just seemed so odd. That was not appropriate. So this was the list I took. And at the University of Chicago, Dr. Christopher Gomez and Dr. Tai G examined me for a couple of hours, talked back and forth. They took all the tests I'd had because I had lots of testing done, but everything had come back normal. Everything. Every test they could think of, sleep studies, everything was normal. So just by their skill and their analysis and the visual examination assessment, they said it's possible MSA. And my first thought was, MSA, what the hell is that? That was what I wanted to title this presentation, but I thought better of it. I had never heard of it. There are a lot of nurses with MSA, and they will tell you the same thing. I have run across one nurse who had ever heard of MSA, and she was married to a neurosurgeon. Nobody else had heard of it. So they said that's what they thought it was. So I took the information I had. One of the world gurus for MSA was supposed to be Dr. Philip Lowe at Mayo Clinic in Rochester, Minnesota. So I took all this information over to him. They had all the lab tests and everything, but they did a spinal tap, which nobody had ever done. My CSF was 84, normal is 0 to 35. This is the first abnormal test result that came back. And so I asked Dr. Lowe, what does this mean? And he said, increased CSF protein is a manifestation that blood-brain barrier is slightly defective. It is known to be slightly defective in MSA. So there it was, the first abnormal lab result of everything that they had done. Now this you can't see very well, but I wanted you to see the graphic. You may not be familiar with it because this is a thermoregulatory sweat test done at Mayo Clinic, invented by Dr. Lowe, and I believe the only other place this is done is at Stanford. And what they have found that people with MSA gradually lose their ability to sweat. So on the left is the first test they did for me in 2018, and the right is 2019. The way this is conducted is you're put into a box like a tanning bed or a casket, whatever you want to call it, and you're in there for about an hour, and they keep running up the temperature inside until your body temperature gets to a certain level, and you're sweating. You're naked, covered with a brown powder, and every place the sweat touches the brown powder, it turns purple. So this is a picture on the left as a graphic of the photograph. The first year when I went, you can see that there's not much sweating on my body. Can't read my writing there. Let me see what it says. The percent of anhydrosis was 54.9%. So I was only sweating on 45.1% of my body at that time. But back in 2019, I was involved in several research studies. At that time, I was only sweating 31.6% of my body. So I'll be going back every year for these tests to see how that decreases. But you can see the slight differences where the purple is where I was sweating, and where the yellow is where there's no sweat at all. So based on all this information, plus a multitude of other tests they did there, Dr. Philip Lowe said possible MSA. He said he wasn't really seeing it that much, but he was pretty convinced it was there. And so he immediately put me in several research studies because he was pretty sure. So I'm in several research studies at Mayo Clinic. The research studies I'm involved in now are for DNA. Everything has a DNA study attached to it. I'm in so many studies, I'm sure every study is going to say there's that lady's DNA again cropping up. It's the same one. But they have a research study that's NIH, National Institute of Health funded, for multiple system atrophy, novel targets in early diagnosis, pathophysiology, and therapeutic approach. The 3-year longitudinal study. And so the results of that, the test results that apply to that one also go to this third study, National History of Study of Synucleinopathies. That's a 5 to 10 year study, longitudinal, and they're looking for predictive biomarkers. And we so applaud anybody who's researching biomarkers because that's what we need. It's so important to our quality of life to be able to get an early diagnosis and get support that we need from different government agencies, home health, those kinds of things. I'm also in a clinical trial with Biohaven Pharmaceuticals. The study, the drug is BHV 3241, verdiperstat. It's a 1-year study for each participant. I understand it's in the United States, I think, since last fall, but they're not taking new participants. They've got about half the number they need. It's supposed to start in Europe, but because of the COVID, it's not started over there yet, so I'm not sure exactly when this one will be finished, but I will be finished in December with this. The purpose is to slow the progress of MSA, and they've had good results, so the Federal Drug Administration in this country has fast-tracked this, hoping to get this on the market sooner rather than later. But that was before the COVID, the coronavirus, so we'll have to see what happens there. So questions that I have that I would love to see researched: is there a greater incidence of MSA in nurses than in the general population? Over and over on the social media pages, nurses keep cropping up and saying, why are there so many nurses with MSA? Or maybe it's our imagination, but I'd like to see the incidence. Another one is, what is the incidence of MSA patients who are very healthy, active individuals prior to MSA? So many say, I was so healthy. Even the researchers in the Biohaven study are saying, we hear the same thing over and over. People going, I was so healthy, started having these weird neurological symptoms. And then something else that I picked up on, what is the incidence of MSA patients reporting an unusually difficult respiratory infection? I had a respiratory infection for about 1.5 years. Nobody could figure out what it was. I was on breathing treatments. I probably should have been hospitalized at one point, but was stubborn, decided to stay home. But so many people said, yes, I had a bad respiratory infection. So it's just something that sticks in my mind when I hear that. So I want to thank you to each one of you who are doing research, for those of us with MSA. And I would like to say, may you and your families be safe, healthy, and grateful during this time when our world pauses. And I'd like to thank the organizations, the Cure Parkinson's organization, the World Parkinson Coalition, and the Van Andel Institute, but especially the people like Rafi who are researching all of this. Thank you so much.
Thank you so much, Beverly, for that very interesting presentation. So we're going to go on and move to the Q&A portion of your session here. So I thought I was just going to start by asking you. So you mentioned that the first symptom or episode was when you were 44 years old and you didn't get the diagnosis until almost 20 years later. And you seem to be very prepared going into your doctor appointments, having all your symptoms and being well aware of them. So I know you have a lot of interaction with other MSA patients around the world. Is their story to getting into a diagnosis similar to yours?
Over and over, it seems to take about 2 to 5 years to get a diagnosis. It's usually diagnosed as Parkinson's first, and then something else becomes more complicated, or it's moving faster than Parkinson's, it seems to be. But yes, that's a very common thread. Yeah,
must be very frustrating those years when you know something is wrong, but you don't have a name for it. You don't know what it is.
We keep going from doctor to doctor thinking if somebody will just tell me what this is, we'll fix it. You know, I should be able to change my diet or my lifestyle or something, but we were all so healthy to begin with, we don't know where to start.
Yeah, can imagine that. Also, I'd like to ask you, you mentioned you've been part of the Biohaven clinical trials. Could you tell us about your perspective as being an MSA patient and being involved in clinical trials? How have you experienced it?
Well, many MSA patients want to be involved in the trials. And of course, this one was recommended to me by Defeat MSA, a nonprofit organization, and so I jumped on it. People have different experiences. There were several of us from the social media page that got involved in the trial. Apparently, I'm the only one who's not been eliminated for whatever reasons. I'm still in it, so I'm surprised. But that's very discouraging for people who were eliminated at the beginning of the trial or partway through the trial. But then they're looking for another trial.
Yeah, I can imagine it must be a very frustrating situation to be in. So if from your point of view, what would you like in regards to clinical trial that could be improved to maybe make it easier for patients to participate or be aware of the clinical trials out there to participate in?
Well, the difficulty is the number of clinical trials. I think because this is a rare disorder, there's not a lot of funding for them. And I realize this, but if you're the one who has the disorder, for you it's 100% and you want something done. But it's when a new patient is diagnosed, it takes a while for them to find the social media pages and the nonprofit organizations that are helpful. But those are tremendous help. MSA Coalition, Defeat MSA, that raise money for research and also put us in touch with other appropriate resources.
Yeah. So we have a question here from Dan. He's wondering if you think you're getting the medication in the Biohaven study. Are you seeing any changes, positive or negative?
Yes, I'm pretty certain I'm getting the medication because I could not tolerate the full dose. You start at a half dose, work up to a full dose. And at the full dose, I had much muscle weakness, anxiety. I just want to jump out of my skin. So we dropped it back to a half dose. That was tolerated. Worked up to a 3/4 dose, and I started having problem side effects again. So I went back to the half dose, and I've maintained that throughout. I probably will maintain that until the end of the study.
Yeah.
Headaches come with that too, and elevated blood pressure.
Okay. An anonymous attendee says, thank you so much for sharing your story today. Was your unusual respiratory infection before or after your diagnosis / onset of neurological symptoms?
It was after the onset of the symptoms, but before the diagnosis. It was in that transition period. I was trying to figure out what was happening. And it was just, I'd never had respiratory problems before, no asthma or anything. And it just, they did all kinds of tests and could never figure out what it was. And finally, it went away on its own after about almost 2 years.
Yeah. What are you doing in when you think about physiotherapy? Are you doing anything to manage symptoms or to improve your the symptoms that you have, or manage to deal with that?
I've decreased the number of medications prior to the clinical trial. I can't change anything during the trial, but decrease the medications because so many of them were making me sleepy. All the brain drugs make me sleepy, and I've told every physician quality of life is the #1 priority. So I think that has helped. So I just maintain a minimum amount of Cinnament and Requip in order to go to sleep at night. And that's about it. I do physical therapy until the coronavirus was kind of put on hold. But I have a whole sheet of things I do at home. I've been through the LSVT Loud program for speech therapy. And I'm starting a different kind of speech therapy this afternoon with voice banking, possibly, those kinds of things. Because I'm concerned about losing my voice. If I lose the ability to communicate, that's very, very serious. And so I watch the social media pages to see how often that happens to other people. And usually at the end of life, people will say, well, his brain was completely intact, but he couldn't talk, he couldn't communicate. And so it sounds like that is probably coming. So I'm going to fight that as long as I can. I don't want to prolong my life, but I want to maximize the quality of my life. And I do yoga, that's true, I do yoga.
Yeah, it's good that there's options to try and prolong that. And I understand that quality of life is definitely the #1 priority.
And for a while I did hyperbaric oxygen therapy. I think that was very, very helpful the first 1.5 years. I didn't have the support of the physicians. They said, if you think it helps, go ahead. But I think it helps with my ambulation quite a bit. But then when I started the clinical trial, there was something in the medication and the oxygen that didn't work together. It gave just really bad headaches and more muscle weakness. So I thought I'm going to continue with the trial and stop the oxygen for a while, and then we'll see what happens after the trial if I pick up and go back to the hyperbaric oxygen. I was doing it in my home. It was so effective. I purchased a chamber for my home.
Okay. So also we have a question here from Simon. You listed a bunch of questions at the end of your talk. But if you would like to tell us as the research community, like, what do you think the researchers should know about MSA?
Gosh, it's not, the patient's the expert, I guess. I didn't know anything about this when I started, but I have learned so much. And fortunately, my physicians will listen to me. I'll go in and say, I think I need this or that, or let's try such and such. And the big help is the social media pages, because that's where I get most of the information from other MSA patients. I myself, having had this for more than 2 years, have never met a person face-to-face with MSA. But I have so many contacts online that say, I've tried this medication, this is my results, so did you hear about that clinical trial, or what kind of bed do you need, those kinds of things. So encourage the patients to use the social media and get contacts for wherever they can. Yeah,
that's a great point of contact, especially now with COVID as well, but to keep in touch with people that you might not have the opportunity to see otherwise because you live in different parts of the world.
Right.
We have a question from an anonymous attendee who's wondering if you think there's a disconnect between the patient community and the research community, kind of tagging on to what you just said.
Well, I think it has to be there. The research is looking through the microscope at the brain, and the patients are actually living it. But I think brain donation is so important. I advocate that for everybody, whether or not you have MSA, donate your brain. And I have to, this is fun because the University of Michigan wanted my brain, and the doctors at the University of Chicago and the doctors of Mayo Clinic. So I finally went with Mayo Clinic, but I said, this is the first time in my life men have pursued me for my brain instead of my beauty. But it's so important. That's the only way they're going to be able to get help with the research. You know, you can do so much in a laboratory, but you've got to have the brain to look at also. But we really need the biomarkers ahead of time to diagnose this while we're still alive, if that's possible. Probably not in my lifetime, but I'm doing everything I can for the next generation.
That's a nice way to look at it, Beverly. We have a question from Christian who's wondering if you had any olfaction or taste altered prior to your diagnosis, maybe, or even after?
I have not. Some people have, but I don't hear that very often from the other MSA patients. But it doesn't seem to have affected mine. And of course, now I would be suspicious. Maybe it's COVID. I don't know what it would be, but mine seems to be fine. Eating is still okay. I have a little bit of a challenge to swallow, but I do think this Biohaven drug has helped the swallowing a little bit. Even though it's not supposed to reverse symptoms, it does seem to in that case with the speech and with swallowing. I guess that's all on that question.
Yeah. And also Christian is wondering, how many former nurses do you know to suffer from MSA?
Well, personally, of course, I don't except through the social media pages. But there just seems to be so many new people come on and say, well, I was this kind of nurse or that kind of nurse. And it's not a specialty of nursing, it's just being a nurse. So we wonder about the environment, but I have lived all over the world. So I think, well, it can't really be environment because some people have never moved from their hometown. Other of us have lived everywhere. It's just hard to say, but often there's somebody that will come and say, I'm a nurse. We had a panel put together for another group of neurologists, and ended up 3 of the 5 of us were nurses.
Yeah,
so it's a puzzle. You know, is it our imagination? But the other nurses that said the same thing. Why are there so many nurses?
Yeah, that's very interesting question. So you talked about some of these resources on social media. Maybe we can have you post them in our Facebook group, or we can provide them on Twitter,
okay,
so we can connect more people.
That would be wonderful.
Other in the community.
We can do that. Thank you.
Okay. Well, thank you so much, Beverly, for sharing with us your story and answering all of these questions. I think this was a very educational talk for many of us. And with that, I'd like to thank all of our listeners, and also, of course, again, Rafaela and Beverly for taking their time and speaking with us about their research and about their personal history, and even their input on into answering the questions that we have here. We are, as you all know, moving on to a 1 per week 3P session on Thursdays. So we're going to have our next session next Thursday, where we're going to have an olfaction in Parkinson's disease themed session. And our first speaker next week is going to be Michaela Johnson, who's sitting here with us. And she's going to talk about our work about regarding PFF, bilateral PFF injections and olfactory dysfunction in mice. And then we have Ash from, she's a PhD student at University of Florida, who also talk about alpha-synuclein and how it seeds in the olfactory bulb and affects neuronal activity. So with that, I'd like to thank you all again and have a great rest of your day. Bye.
Thank you. Bye.